Okay, and next, Dr. Tony Spirito is going to share his thoughts about where we need to go from here.
Thanks very much, Mitch and Eric, for inviting me. I'll start by saying, for you students in the room who are interested in clinical research, I've been conducting clinical research with suicide attempters for 35 years. So there may be some hope that you too can move forward. If I can do it, I think you can do it. The second thing is this will be the first time I've ever worn glasses to read my notes. So I have no idea how this is going to go. So good luck. They're not very fashionable, but they're only $2 from CVS. But I can work. So I'm going to try to see, this is going to be a pain in the ass. I am going to try to talk about the intersection of clinical care with clinical translational research, because the goal of clinical translational research, which we've heard so much about this morning, is to improve patient care. So what I want to talk about is some challenges to that and to lay out some questions for you that you might consider in your discussion points. I should point out that one reason I'm doing this is because I know nothing about technology. So I really can't comment on technology. So it would be ridiculous for me to try. I'm also the outlier in the room because I also believe that most of the clues to the future can be found in literature and rock and roll lyrics. So I'm going to use that premise to do this talk. But let me just start with a cautionary tale. And that is, for 5 years, I ran a pediatric headache clinic with a pediatric neurologist. And I did a lot of biofeedback, and she would refer me a ton of patients, and she was great, and we really worked well together. So when she would start to refer me patients after 2 and 3 years, I would say, this is a good biofeedback patient. I'd say, good, bring them in. So I had a 15-year-old girl come in with her mother. And so I brought her to the biofeedback room, and I hooked her up to EMG, and I did the GSR, and I explained how it worked, and I did the whole 9 yards. And I'm walking out, and I said to the mother, we'll just go to my secretary, we'll make an appointment for biofeedback. And the mother goes, this biofeedback stuff is pretty cool, but all she really wanted to do was talk to somebody. So you may say, well, he's just a moron and a terrible clinician. How could he not even ask about that? But my point is that you can get seduced by technique and technology. And we do need to step back and think that we are clinicians, most of you being trained in clinical psychology, I assume, and that we do need to step up time and not get seduced too much by that. So within the context of those discussions, I do have to I'm going to give you a couple quotes to think about. So the first is from When Breath Becomes Air. Science may provide the most useful way to organize empirical, reproducible data, but its power to do so is predicated on its inability to grasp the most central aspects of human life: hope, fear, love, hate, beauty, envy, honor, weakness, striving, suffering, virtue. And the second quote is from Tom Insel. I spent 13 years at NIH really pushing on the neuroscience and genetics of mental disorders. I think $20 billion, but I don't think we moved the needle in reducing suicide. So with those two contrasting quotes, I want you to think about here I'm going to pose some discussion points that you people can think about, and I've been thinking about. So explain how you would integrate both the understanding of the human condition and neuroscience and genetics in a way that we can actually reduce suicide over the next 13 years. You can disagree and say we don't need to integrate those two things, but think about it. And the second thing I would say is you should discuss how neural circuitry underlies deaths of despair. We know over the last 2 decades that there have been a huge increase in deaths of despair, which is suicide and alcoholism, in middle-aged, white, non-Hispanic men. Let's take that into account when you're thinking about how to push forward the agenda to reduce suicide over the next 13 years. And maybe even a bigger question, if you think that societal factors play a role in suicide, then is the reduction of the suicide rate really an appropriate goal for NIMH? Certainly they should try to reduce the suicide rate, but they should they be judged by their success if they do or do not move that needle? I think it's an open question. You may not think so. But let's take some of the risk factors that we know a lot about from rock and roll lyrics and work from there. So the first one is, here with you, there's always something to look forward to. My lonely heart beats relatively easy. So we know that 33% of millennials say they're lonely. So how would you develop a treatment or an intervention or a selective prevention program to address loneliness and social connectedness in adolescents to reduce the suicide rate over the next 13 years? And what I would say is consider the whole range. So consider biological treatments like oxytocin, should we be treating them that way, all the way to social media interventions. So take that as one example. Think about that. It's not the sleep that I can't steal that wires me. If sleep always comes up as an indicator of suicidal behavior and death by suicide, then I propose that all highly suicidal patients should be treated with sleeping pills. So argue that side of it, yes or no. If you can see the faces right now, a lot of you are disagreeing. So if you disagree, develop the behavioral intervention that will improve sleep, that doesn't rely on patient motivation. I ran a sleep clinic for 5 years with a pediatrician, and you need a little motivation to change adolescent sleep. The third one, it's not the third one, I'm all confused. Implementation science. Let me just move to that a little bit. Like we're talking about neuroscience here, but implementation is a science too. Let's think about what implementation science can do over the next 13 years. And there are a couple areas where it could work. I need the white, she gets the blues, it carries us on through. Tell me if this headline will make it in 13 years. The equal focus on training mental health professionals to treat substance use disorders is what made the difference in reducing the suicide rate over these last 13 years. Or consider this headline. I've been lost, I've been found, I've been taken by the sound of my own voice and the voices in my head. The training of mental health professionals to identify and treat clinical high risk for psychosis is what made the difference in reducing suicide in 13 years. Or, let me find my last one. All my past is like today, monsters and horrors no one wants to hear. Or it was the training of mental health professionals to treat trauma that resulted in the reduction of the suicide rate in 2032. Just a couple more for you to consider. Under assessment, when you think about the assessment, and we've been talking a little bit about that today, and especially EMA assessment, David Foster Wallace said, no single individual moment is in and of itself unendurable, but he hung himself. So how would EMA and EMI be sufficiently applicable to the highly suicidal, severely depressed, and impulsive individual? There's promise for that technology, but can we address the ones that are the absolute highest risk, like David Foster Wallace? If the key to reducing suicide in 2032 is such a protocol, then we really do need to focus on those who are most at risk and how to identify them, and will those patients use the technology? On a scale from 1 to Sylvia Plath, I'm about a 4. The key to reducing suicide in 2032 was determining for what subsets of suicidal patients is continuous monitoring of suicidal ideation beneficial, and for what subset is it iatrogenic. I think you're projecting the way that you're feeling. I'm not suicidal, just idling insignificantly. The key to reducing suicide in 2032 was funding studies that focused only on patients with active suicidal ideation, the most high-risk patients, so more research is devoted to that population. Or take one of these positions. In 13 years, we'll find out that the application of artificial intelligence techniques and machine learning to electronic medical records proved to be a boon to suicide research because we found novel markers that we could intervene on and reduced suicide. Or alternatively, the electronic medical record can be attributed directly to the increase in suicide over the next 13 years because of the time it takes away from medical and mental health professionals in providing patient care and its association with clinician burnout for the amount of work you have to do with medical records. Just a couple comments on treatment that you could think about for 2032. Neuroscience findings have led to the demise of psychotherapy. Or psychotherapy will remain a treatment technique, but its form will change because it will need to be neuroscience informed. Or avatars will become so technologically advanced that they will begin to replace humans as therapists. Or in the era of technology, you're laughing, but there's this thing at USC that's getting incredible. It's called Sensi. It's an avatar that they're using for therapy, and it is very advanced. So don't laugh so much if you want to be a therapist. In the era of technology and mental health care, the expert therapist will actually become the highest calling in the mental health profession. Pick one of those and defend or discuss. Who said, I'm not a big fan of psychoanalysis. I think if you have mental problems, what you need are good pills. You can ask me later if you want to, about any of these quotes. How likely is this headline in 2032? Ketamine proved promising as a means of reducing suicide until it became overprescribed and we replicated the opioid crisis. So one final point. We're civilized people. We keep our shame and suffering to ourselves where it belongs. No one laughs at that? I guess you could sew in my head, all these things are really funny, but you have to, I guess that's why I'm. Let me read that again, because this is really funny. How am I supposed to end the talk on a funny note and have no one, Jesus Christ, I'm not coming back here. One more try, ready? Okay, we're civilized people. We keep our shame and suffering to ourselves where it belongs. Thank you. And this is only tangentially related, but psychiatry actually invented personalized medicine. It's called case conceptualization. And it really amazes me that it never gets discussed at all. And even at a more narrow level, of course, functional analysis or behavioral analysis is really the essence of personalized medicine. So discuss why you think case conceptualization has diminished in its importance in training and in clinical care. And when you do so, you can consider a few things. The emphasis of diagnosis now in clinical care, an untoward effect of the push for its evidence-based practice, which may reduce people's inclination to do case conceptualization, or the effects of the EMR, where the most important thing is to check many boxes as you can to maximize the bill, as opposed to write a thoughtful note about a patient as they present. And I'm looking at Grant Emsley standing there, who was trained 40 years ago to understand a patient when they came into the hospital, as opposed to understand the regulatory mechanisms. So, and what you should do is try to devise a template for the case conceptualization that we'll be using in 13 years, because that case conceptualization will need to include all the traditional things of a behavioral analysis, but it must also probably include neuroscience biomarkers that we're going to become more informed about. This is a place where our doc can actually help with the new case conceptualization that psychiatry will tout, and also consider the human condition in the context of conceptualizing a case. So those are my major remarks, but let me close by saying this, and this is specifically for David Goldston. I ain't always right, but I've never been wrong. It seldom turns out the way it does in a song. And I know he knows this song. So I'm not naive enough to think these comments and that technology and neuroscience won't drive the field. And in fact, I'm sure right now in some basement room in DARPA, there's something being studied that will have an amazing application to mental health and to suicide in particular in 13 years. But I don't think we should just totally focus on that and forget our traditions. That song goes on to say, God, I can't remember. How could I not remember that? Once in a while, you get shown the light in the strangest of places if you look at it right. So we're trying to look in strange places to find really cool things that will help us move the needle and reduce suicide rates. And I think that's good, but I don't think we always need to look in strange lights. We can look in familiar lights and may have a way to reduce suicide in 13 years. 40 years ago this month, I was collecting my dissertation data. And what I was doing is doing neuropsych testing in the schools for kids with writing problems. So I would go in and test them, and the teachers would do behavior rating scales for me. And then I'd go back and pick up the behavior rating scales. And so one time I went back to a classroom, and the teacher gave me 2 packets, and she said, here, I asked this class to do this assignment. You'll find this interesting. I asked them to write, what is a psychologist? These are 4th graders. So that was really cool. And over the 40 years, I've lost that packet because it had really great definitions that I would love to read right now. But there is one I remember. And unfortunately, this one didn't come true over the last 40 years. But I hope the next 40 years, this will come to fruition. And what this boy wrote was, what is a psychologist? A psychologist is a science man with magic and potions. So to hell with technology, that would really be cool.